Okay, good afternoon, audience here and also audience online. I see that we are close to 100 people online. So good afternoon and maybe good morning to some of our registered. They are from overseas. So today is a great honor that we have invited Dr. Natalie Chandler to share, her work. And it's also my great honor to introduce our chairperson today because, this work is not just in an academic setting, it's more relevant for our local healthcare system. So I'm very honored to introduce our moderator today, Dr. Leung Chang. Dr. Leung is the consultant and also related with a lot of the leading program of the genetic and genomics in Hong Kong under the Hospital Authority. And today is my great honor to invite Dr. Leung Chang to chair the scientific program today and the talk by Natalie.
Thank you very much, Richard, for your kind introduction. And indeed, it is my great honor and pleasure to be able to moderate this session. So Dr. Natalie Chandler is the principal clinical scientist of the Rare and Inherited Diseases Laboratory in the NHS North Thames Genomic Lab Hub at Great Ormond Street Hospital for Children. She has multiple awards and is also holding important positions. And I think her talk today will be very useful, especially for our purpose, because I'm a clinician, not a laboratory person, but we are coordinating the our NHS, that is we call it a hospital authority, using the public-funded algorithms for the prenatal diagnosis. And I know that Natalie is going to share with us her very precious experience in the NHS system, how to translate the research evidence into clinical practice and how to evaluate the outcome. I think this will be a very strong and very useful reference for our current and also coming programs in Hong Kong. So without further delay, I would like to invite Dr. Natalie Chandler to start giving us the talk. Natalie, please.
Thank you for the honor of inviting me to come here to give this talk. So just my background, I am a clinical scientist, so I'm a scientist trained in variant interpretation and clinical reporting. I have a PhD background, but I've now moved more into research, and I run the translational research team in the North Thames laboratory. And our job is not just prenatal, but all the tests that the lab offers is to develop new technologies and bring them into clinical service. So just to explain how the genomic medicine service in England works. So we are split into 7 different genomic laboratory hubs. So North Thames is this dark blue one here. It looks like the smallest, but actually probably has the highest population out of all of them. We have a national genomic test directory, and each test has defined eligibility criteria and set panels and technologies that must be used. Thank you. So so the whole idea of the National Genomic Test Directory is so that no matter where you live in England, you will get exactly the same test. And so no differences. So these are some examples of some of the prenatal tests that the Genomic Medicine Service offers. So Great Ormond Street leads the organisation for the North Thames GLH. We have a population of 10 million in our area. But we have to deliver cancer somatic testing, karyotyping, arrays, and also core tests that's assisted by races and FH, all within that. So that's what we call core testing. So each laboratory hub will have to provide that core test. So each of the 7 different centres, but there's also specialist tests. So the groups are NIPD, renal, metabolic. So we go into groups, and so not every hub provides all of those tests. So for a lot of them, only 2 labs in the country provide those tests. So for prenatal, there are 2 centres. So there's us and the Birmingham laboratory in Central and South. And so we offer the specialist prenatal tests, which include non-invasive prenatal diagnosis, and the R21, which is the fetal anomaly sequencing test, which currently is exome. So what I'm going to talk today is kind of all the work, how we kind of develop these tests and how we got NHS England to kind of fund them, and how we move from research into clinical services. So our main focus has been trying to move invasive testing to non-invasive wherever we can, and this is diagnostic tests rather than screening. And also trying to move from doing arrays and karyotyping to kind of down to the base pair and doing more comprehensive prenatal diagnosis. So I'm not going to talk much on screening. So this is what kind of where genomics has transformed the prenatal diagnosis service. So we have the 12-week scan where you do the high nuchal and do the screening. And if the screening comes back high chance, the 13, 18, 21, previously you'd have invasive testing. But nowadays you have NIPT. We did do the rapid study to kind of justify that being moved into the NHS. So our lab no longer does the testing. So I'm not going to talk about that in great detail. And I think other centres are kind of doing more comprehensive testing than the NHS, so I won't go into that one. So what I'm going to talk about are the cases where you've got fetal anomalies and the tests we've developed within the NHS to expand on the testing available for those conditions, and for those with a family history of immunogenic conditions, and moving towards trying to get as many as those to non-invasive testing rather than invasive. So to start with our non-invasive testing, so we work with cell-free fetal DNA, for those of you who don't know much about it. So it can be detected from 4 to 5 weeks gestation in the mother's blood. The concentration increases as the pregnancy progresses. It's what makes it ideal for diagnostic reasons or screening reasons. It's cleared from circulation within 30 minutes of delivery, meaning it's fresh for each pregnancy. And the fetal fraction can be anywhere between 4 to 20%. It's very variable. And the majority of the cell-free DNA in the maternal blood is the maternal cell-free DNA. So you do have the challenge of that background. But it has been shown that the entire fetal genome is present in the cell-free DNA. So I think it's important we talk about definitions for our service, because mostly the things you'll hear about in the literature and in the reports are all the common aneuploidy testing, which many patients have. This is testing or screening for aneuploidy, and there's risk of incorrect results due to confined placental mosaicism or other reasons. So you must always have invasive testing for confirmation. But what I'm talking about today is diagnostic tests. So these are just for high-risk pregnancies. So these are ones where you've got a family history of the condition, you're testing for the familial variants, or you've got ultrasound scan highly indicative of that disorder. Therefore, if you've got a variant, it's very much likely to be causal of that condition. We say that you do not have to have confirmation of the result. So we first started very simple conditions where the marker of the condition is not present in the maternal plasma. So you're just looking for the low level marker, either de novo or from the father. So we started out with just the Y chromosome. So we're just looking for a presence of marker of the Y chromosome in the mother's blood. And so this we simply did by qPCR, quantitative real-time PCR. And so you're just looking for the presence or absence of it. And so we managed to roll this into NHS service, having done it in the research test, I think about 6 years prior to being able to roll it out. And it was accredited from 2011. And we do about 450 tests a year in our centre in England. And there's also the Birmingham lab not included in these figures that do their fair share as well. And it's been deemed, the reason the public will fund this is because it's seen cost effective, because if you can just test the blood sample for X-linked conditions, for example, you won't do invasive prenatal testing on female pregnancies, for example, so it ends up being cost effective. So the next test we then went on to develop was FGFR3 and FGFR2 screening for specific variants, because these are all conditions that have key hotspot variants in cases with scan anomalies indicative of the disorder. So we have a panel of 29 FGFR3 variants and 28 FGFR2 variants. We have a very simple method to do this. We literally do a PCR and then just do deep sequencing. It's nothing complicated. We're lucky with FGFR3 and FGFR2. A lot of the variants cluster very close together, which means you only need to do, I think for FGFR3, it's 6 sample cons to do the 29 variants. And FGFR2, I think it's only 4. So it means it's quite cheap to do. And yeah, we've had really good outcomes. We've had no false negatives, true false negatives for FGFR3. We've had one where the variant wasn't on the panel, so we've since obviously added that in. But yeah, we collect outcomes, and so far we're at 100% concordance. So that came into use in the NHS from 2013. We do have a cutoff of a 1% fetal fraction just to make sure we're not getting any background. But yeah, so it is currently funded in the NHS for abnormal scans for FGFR3, but also at the moment we will fund it if there's a family history or they've had a previous affected. We are planning on taking out the public funding of it if it was de novo, because we've not had any recurrence for FGFR3 or FGFR2, and we don't think it's good use of public money. So then we wanted to expand our testing to as many different conditions as we could. So we introduced our bespoke service. So we developed enough assays and had confidence with our FGFR3 and the technology. So we're like, well, actually, you could expand this to anything which isn't present in the mum. So any paternally inherited autosomal dominant condition, any de novo variants in the fetus, and also recessive cases where parents carry different variants. You can test the paternal variant, and then if it was detected, you could then do invasive testing. So this has been really successful. We implemented it in 2016. So data from last year, we had over 300 families across England who'd been offered bespoke testing. We've done 276 unique variants and 190 genes. 25% mutation positive. The reason why it's not 50% is obviously we have the de novo category in there, and also quite a lot of the recessive cases, sometimes they will have PGD, and they use this result to confirm the PGD. So we are below the expected 50%. So again, this is funded by the NHS for paternally inherited variants, so anything where it's 50 or 25% risk. It isn't funded to do de novo testing because we have done, I can't remember how many now, and we didn't have a single recurrence of the de novo. However, I think this year we did have one case where it must have been true germline mosaicism where it was affected, but still that number is not high enough to justify the public spending. One thing that we have had from developing our bespoke assays is we've detected a lot of parental mosaicism that was missed by the original test. So if it was Sanger sequencing or exome or genome, the depth is so low that it was missed, or they didn't expect the parental reads. And then we've done a depth of 20,000, and so suddenly one of the parents is then a carrier, and then for them that's really important information. So if they're paternal, we can still offer NIPD. Obviously, if we've got the maternal mosaicism, we can't offer NIPD because we can't distinguish between that background. But it's actually really important information because their recurrence risk could be as high as 50%. So it's just one of the limitations of our test that we do say, just make sure you cancel that NIPD may not be possible. We do receive quite a few referrals internationally as well. We receive them from Australia, New Zealand, America, all over. So we're always happy to accept new referrals. So then we also wanted to expand away from just paternal variants and de novo variants. We wanted to find a method that works for maternal variants. So obviously here we have the challenge of the maternal variant, the background, and trying to do that distinguish that slight imbalance. So with this single variant, it's really challenging to not get incorrect results. I think every study has had at least one incorrect result if they tried to use relative mutation dosage. So Dennis Lowe from Hong Kong came up with a solution. So instead of just looking at your variant of interest, what you can do is use kind of a old school linkage analysis and take thousands of SNPs. And if you've got the mother, father, and proband, you can work out what the high risk allele and what the low risk allele is. And then with the thousands of SNPs, you have the statistical power to be able to detect which variant is, which allele is inherited. So we always say allele rather than variant, because there can be obviously risk of double recombination events between our haplotype blocks. So it is a linkage-based test. The great thing about RHDO is it can be used, it's mutation agnostic, so it can be used for any variant, deletion, duplication, it can work for any variant, it can work across pseudogenes. So it has great methods. The disadvantage of it is quite expensive to do, you have to sequence a lot of samples, but we've managed to convince the public NHS funders that if you take into consideration the cost of the consultant taking that invasive sample into the cost of the testing, actually it works out being around the same cost. So RHDO we've done now, so this method is called relative haplotype dosage analysis. So we've brought it into service for cystic fibrosis, DMD, Becker's muscular dystrophy, SMA, CAH, and then we've just validated the HBB gene, which is sickle cell and beta thalassemia. It takes a while to roll it out into the public health system to get NHS England to fund it. So that's currently going through the cogs. And we've done over 500 tests and we've got no discordant results. I say there's the risk of the recombination, double recombination, or we can't do anything about de novo variants or conversions. Twins, pregnancies, obviously, if they're not identical twins, they're very challenging because you have different haplotypes. So we'd always recommend invasive testing. It has been in the past a challenge in consanguineous families, which in England there's quite a high ethnic population, not just for certain religions. We also have traveller families, etc., where consanguinity is high. So before we weren't able to offer testing because they share the same haplotype, and therefore we weren't able to do phasing. But we've just developed a new method that was published this week in clinical chemistry, which means we can now expand and because equitable access is really important in the public health system. So we've been able to expand to all patients, which we're really proud of. But the one thing we do need quite a high fetal fraction for the haplotype analysis just to work. It has to be around 4%. It's not a set cutoff. We have like criteria things, but kind of the balance works out of being around 4%, but it's not a strict cutoff. Now, one of the main exclusion criteria is that you do have to have samples from the father in previous child or pregnancy, and these aren't always available, especially if they come through carrier screening, etc. But it's still very popular. So what challenges have we had like developing these services? I think the two main ones that we've really had to get these accredited have been how to do the verification and the validations for each test. And then we have to participate in EQA to be accredited. So how do we do EQA when we're quite unique in our service? So the validation for rare diseases, it's not possible to validate all genes or variants, so you have to validate your method. For FGFR3, we use a limited number of variants and compared our results to outcomes, but we've now managed to do all the variants. We have our rapid sample biobank. For FGFR2, it was the same technique, so it was easier, and same for the bespoke. We did 113 samples compared to be able to bring it into diagnostic use. We needed to show that all the different variants we could do before we were able to offer in clinical service. RHDO, it's even more challenging because you can't just do one case. It's really costly to buy the probes. So we're kind of going lower. So we're now down to about 6 cases for us to be happy with the validation, but that means we can only really offer it to common conditions. EQA, well, so us and Birmingham, the only 2 labs as we know in the world. I know China has some RHGO services, but they're different conditions. So how do we do EQA? The only thing we can do is we can do a sample swap with each other. So that's what we can do, and that meets the requirements. But if there's more and more labs wanting to do NIPD, we're quite keen to get some EQA schemes working up with GenQA or another company. So one thing we always do when we're introducing new services in the health service is also have our social scientist team do studies to review the views, equity of access, how we can improve educating our health professionals and the counselling. So these are some of the views from patients. So they're overwhelmingly positive about NIPD. Its safety is highly valued. The early diagnosis, so you can do it from an earlier gestation in invasive testing. You can do it at 9 weeks, and for some ethnicities, this is actually really important. So that's really valued, and they want the service. But some of the negatives of being like they would at the moment, it has to be accessed through clinical genetics. We prefer it to be more mainstreamed in fetal medicine units. There's a lot of concern over potential commercial direct consumer testing in this area where there's no counselling and no information on risk of false negatives, for example. And there's a lot of concern for it just being a blood test, and therefore there's no risk. Therefore, where do you draw the line on screening from patients as well? So this is how the service is taken off. I think since the test directory has come in, it is now harder and harder to get new conditions in. We have to do a lot more research to kind of justify the public funding. So we've kind of had a bit of a lull with COVID on getting new tests in, but we're just starting again with HPB, and we're planning on, like, we're trying to do new technologies as well. So hopefully we'll start to grow more. Our turnaround time officially is 21 days, but we don't believe in the 21-day turnaround time. We feel like it should be quicker. The Birmingham want to do 21 days, but we always say 5 days for our lab. And it just continues to grow. And so we're always happy to receive referrals. Where are we going? So the NHS are actually really supportive of this, and they're funding us through the sort of Prenatal Genomic Medicine Network of Excellence to develop more and more things non-invasively and look at more and more technologies. They're really keen to try and get rid of invasive sampling. I don't think it'll ever go, but we'll try. So yeah, we're also exploring long read sequencing for indirect parental haplotypes, so we can get rid of the need for a proband. Obviously, it's got costs associated, but we'll have to see how we do. And then we did a study on droplet digital PCR for sickle cell and had like a 99% correct rate, but not quite the 100% we need. So we're now tweaking things of our assays and how we get fetal fraction, and we're working with Bio-Rad to try and get that to 100% so that we can just do it from maternal blood. We were quite keen to develop non-invasive larger panels or whole exome sequencing to enable screening of more genes. And another thing is auditing all our invasive prenatals to identify where there's most need for non-invasive testing. So that's NIPD. I'm now going to move over to our work on rapid fetal sequencing. So before we could get anything rolled out in the NHS, we have to do a lot of research. And so this was done by us, but also done by a number of studies in the literature. And all the studies were pretty concordant that exome sequencing in fetuses, this is exomes, most of the data back in the day was exome rather than genome. Fetus with structural anomalies increases the yield by 31%. And all the studies were showing, they allowed accurate counselling and an aid informed parental choice and informed future reproductive choices. However, it's a costly method. Can you do it quick enough for prenatal use with the termination laws? Which fetuses would benefit from this test most? Is the actual ultrasound sonographies, is the scanning quality good enough? Can we improve it? Do we need to improve it? And are the phenotypes different pre and postnatally? So there were still a lot of challenges, and they were we had examples within our cohorts showing this, the complexities. So the study we were part of in England was the PAGE study, and that was basically looking at what groups would benefit from sequencing services the most. So it was broke down to the different conditions. So we can see that skeletal had one of the highest yields of 20.4%. Hydrops again was very high, but things like increased nuchal had only like a 3% clinical utility. So from this study, we were able to put together a set of eligibility criteria of kind of conditions we felt would be better suited to public funding. So once we'd got that data, the next question was, can we deliver it quick enough? So we did a study just on the skeletal dysplasias. We managed to do a turnaround time average of 5 to 10 days. And we did between, it was around 5 to 21, and we had a real clinical expert review the scans. So Lynn Chitty actually reviewed all of the scans for the cases coming in to determine whether they're likely to be actual skeletal dysplasia, meaning we got a diagnostic hit rate of 84%. So if you have really good, we can't replicate Lynn, so we had to pass it down. But if you have a really good person reviewing your scans, you can get really high yields. We weren't the only study, so there were lots going on. So the PAGE was a completely unselected, so every anomaly, no clinical genetics review, the FMUs just sent them straight in. But there were a lot of reports coming out where clinical genetic review had shown to really increase the diagnostic yield. So this was shown to be really important in the utility and the public funding. So from that, we were able to convince NHS England to fund the sequencing service, but it had very strict eligibility criteria. We were delayed by COVID, so we didn't roll out till the 1st of October 2020. We were kind of running it on a research basis for a little while, which is great because it means if you can run things on a research basis before clinical, it gives you time to train your staff and get all the systems up and running, your report templates. So it's really great to try and do that before you bring something into clinical use. So our criteria is that fetal structural anomalies detected on prenatal imaging where multidisciplinary review, which must include clinical genetics, considers a monogenic disorder likely, and diagnosis may influence pregnancy management or early neonatal management. I think that's really key because a lot of patients have already decided on terminating just based on the scan anomaly, so it's make sure it's going to impact on that actual pregnancy. We have a set list of conditions that qualify, unsurprisingly skeletal dysplasias on there, major CNS. We are expanding this, but the method for expanding, we need to do a lot of work to justify the cost. We need to look at how many increased numbers. It's not an easy task to do. So at the moment, we're working on getting isolated microcephaly, for example, on the list. This is how it runs. So we have 2 MDTs. So one is when we get the referrals coming into us, we have an MDT to discuss eligibility. It sounds like there's quite a similar system in for the public funded cases here. Then the samples, if they're agreed, the case is eligible, the samples will come to the 2 testing centres. We do the WES, and then if we have any variants that we are at all interested in or we think are plausible, we will take them to MDT to discuss with the clinician. Sometimes even if they're obvious, we're just like, we think this is definitely the cause. Are you happy for us just to report? And it explains fully the phenotype. Sometimes it's really complex, multidisciplinary discussions about whether to report a VUS, incidental finding. Is it incidental or is it actually the prenatal phenotype that's just not been described? So that MDT is really key. Sometimes we have to confirm variants. So we have a set of QC that a variant will need to hit for us to confirm it or not confirm it. So that's sometimes we'll have to confirm. And all of that we have to do within 3 weeks, but we are trying to get it down to 2 weeks. I think it's the confirmation when we do have to do it. It takes time to get primers in. And so that's why we need that extra week occasionally. When we introduce any clinical service, we think it's really important to evaluate it and show the NHS that the money has been really well spent, and make sure that people are accessing it no matter where they are and what religion. So we, at the same time as launching the service, we launched the Express study to evaluate the service and improve the quality of care and equity of access. So that ran from the start of the service, and it finished in September 2023. So the team are busy writing it up. So you will be hearing more about that in the next few months. So this is how Express works. So they're doing lots of interviews and observations and analysis. They're looking at all the care pathways in the 7 different hubs and how they differ and how things can be improved, what's working well, what's not. Our patients understanding the testing from the counselling they've got, where can we improve? We work with patient groups. So we have ARC, which is assisted reproductive choices, who counsel a lot of the patients who are having this prenatal test, and just identifying areas where there's gaps. We also establish all the outcomes for all of our cases. We're collecting them wherever we can. We're looking at the diagnostic yield, anything where we've not got the diagnosis and we've missed it, we want to know about it so we can change our test. Try and identify regions that have got variation in outcomes. Any ethical issues that we hadn't considered at the start that have come up in the testing and the ethical framework. I think a lot of this has been a lot around incidental findings have been really challenging. The costs and cost effectiveness of the pathway, how it can be improved, and then put all these practices together and try and come up with some best practice, at least in England. We're also trying to work internationally to work on best practice recommendations as well. So this was the service up to November 2023. Our diagnostic yield, it just stays the same. This 30, 31, 30.5. Every study seems to have a very similar yield. TOT has been about 14%, 14 days. There has been about 400 were declined, most of those because it was felt like they didn't fulfill the eligibility criteria, or we might suggest an alternative test like Becker-Friedman syndrome because imprinting disorders aren't detected by sequencing, or some of the anemia genes aren't on the panel, so we need to test it. Like we've suggested having a different panel test. And quite a lot of the parents have declined invasive testing, so that's where the NIP moving towards doing it non-invasively has come in. Of the 1,533 that were accepted, a significant proportion did not proceed. Some declined exome sequencing, some eventually opted for TAP. Some had the baby. We had one case of 100% MCC in the CVS sample, so obviously couldn't test that. And then others, while we were waiting to do the test, they had a diagnostic result for array or qPCR. So we have occasionally reported single variants in autosomal recessive genes. These are only undertaken with multidisciplinary team discussions. Normally the cases have been because there's a biochemical test that could be offered, or it's where we've got incomplete coverage and it really fits the phenotype. It might only have 87% coverage and it's felt like maybe WGS or something postnatally might then improve the coverage. Or some cases we do look to see if there's any intronic variants published, and therefore we can do a targeted Sanger to try and resolve some of these cases. We started the service thinking, oh, we're not going to report any VUSs. That soon changed because there was support from clinical saying, you know, we can postnatally follow this up, and we think it's really important to know about it. The phenotypes evolve prenatally. Some of them we've gone from VUS to diagnostic just due to scans. So we have reported 40% relevant VUSs, and we've had at least 20 incidental findings. A lot of these are BRCA related because BRCA1 is on our panel. They're quite challenging, and it's still, I don't think we have consensus in England. The different clinical genetics teams sometimes ask us to report in the fetus, sometimes ask us only to report in the parent. So I think it would be really good for us to have a national consensus on what we're doing. But I think internationally that would be very challenging to have some consensus. This just supports the use of like a very large panel of gene agnostic. We've not I mean, we've had PTPN11, which is no surprise, and Noonan's is our biggest hit, but we've had such a vast range of genes. We've also collected data on whether the exome sequencing has impacted on the management of the pregnancy, and it has been done in 56% of cases. So unsurprisingly, it's much higher for the cases with the diagnosis than the ones without an undiagnosed cases. And this I'm really pleased with, because this shows that the patients have been counselled correctly. Because the exome sequencing, if you get a what we call a no primary findings, it still doesn't mean it's genetic. It still doesn't mean the scan anomalies aren't bad. You have to be cancelled on the scan, and actually, therefore, the genetic test, it shouldn't be particularly reassuring. You know, you need to be cancelled on the severity of the scan findings. So this shows hopefully that the counselling is being done well. A range of different inheritance patterns. But one thing we have noticed that we've got a high amount of 10% of cases were inherited dominant conditions, particularly high drops and the lymphatic malformations, the capillary malformation conditions. The parents don't think they're affected, come into us as unaffected, but we find these inherited conditions and then go back and review the parents. Most of the time, the clinical geneticists haven't even seen the parents. So they haven't done a review, and a lot of the time, actually, yes, they've got mild features or they've got a family history of the condition that was not known about. Or we've had mosaic parents as well. So this kind of shows that panel agnostic and inheritance filtering isn't just the way to go. You also need to consider inherited dominant conditions as well. So we get the outcomes and measure clinical impact. So this is just in the first year. We don't have the data for all of the ones since then. We are collecting it with the Express. I just don't have the data yet. So of the cases from the first year with no pathogenic findings, one of them who'd had postnatal testing afterwards had a diagnosis and a gene that's on the panel. We do use a panel in England. We have the UK panel at fetal anomalies panel. It currently has 1,300 genes, soon to be 1,500. It's not ideal. It's really hard to keep up the literature, but it's because the fetal medicine clinicians are not educated enough to deal with the complexities of exome results. Until we feel like they have more education, we don't feel like we can be doing fully agnostic work with the incidental findings and not being able to link them back. So we try to just keep it to genes that have a known phenotype prenatally. We're doing a bulk of work now in the Network of Excellence and looking at panel using gene agnostic analysis along with the panel to get the inherited dominance, and kind of looking and interviewing people when they'd want their incidental finding results. And we're doing a bulk of work because we know eventually we want to move to panel agnostic. I know we've had at least 2 cases since this where we've missed diagnosis because of mosaic variants, which have been found prenatally. So that's one thing I want to improve is our mosaic calling from our pipeline. We can see them in the data, but obviously they're being filtered out because they're not high enough quality variants. We also look at the cases and we try and follow up the ones that we're turning down. They're not meeting eligibility criteria. There was 3 cases where they just had short femurs. So this now would be in our eligibility criteria, but in the first year it wasn't, and they had Zellweger syndrome. And then there were 2 where they actually they were committed to the pregnancy or TOP, so they didn't have the testing and they had genetic diagnoses. So this is a paper I published in 2022, and it was just kind of went into all the different challenges we've run into offering the service and how it's not easy and how we've addressed these challenges. I think the VUSs remain challenging. Non-coding genes, obviously we're doing exome testing. So for us, we have to spike in if there's a non-coding region we want to add in. So it's really challenging for exome. It's a real call to move to genome. Incidental findings, really challenging, no consensus on what to report. Challenges for inheritance filtering, let's say quite a lot inherited, and you need to make sure you're considering your CNVs, and hopefully with mutagenome we can now get the structural variants with both types. Must be built into your pipeline if you're going to be using inheritance filtering. Copy number variants, so we should detect a number even on exome sequencing that arrays missed. We've run into non-paternity cases, only one so far. I hear that's more of a problem than they've had here. And as I say, mosaicism is something we also want to work on to improve our calling from our panel. So these are just some of the views from parents and health professionals. So again, they've been really positive generally about the service, the communication, and how quickly we've been able to do stuff. The parents have been appreciative because they find the uncertainty is the worst thing. So actually having a result really helps them. A lot of the challenges has been not necessarily the actual testing, but getting the clinical genetics and the fetal medicine units to work together. So there's been a lot of challenges between those teams. So that's one of the main challenges and what we need to work on. And I think for the patients, I think it's just so much information in such a short time and trying to get that support, and they have to make decisions of really stressful times. So I think the poor patients really need some support with this testing, which is challenging in a public health setting environment to be able to give that support, because our counsellors are also NHS funded and have a lot of demands on their time. So what do we want to do next? So we want to develop our sequencer service. So we want to respond to our Express study and look at service evaluation and how we increase education and optimize the care pathways. Our panel, we need to improve how we're developing it if we're going to have to keep it. So we're trying to kind of, at the moment, it's kind of been led by the scientists in the labs developing it, but we feel it's more clinicians that should be developing a panel because we're not experts in prenatal phenotype. So we're trying to move it into the clinicals and have teams where like they should be adding genes as soon as they've read a case report, they should be adding it. And so we're moving more on long time. So we're trying to work on that. Yeah, so we're doing a bulk of work on looking at additional findings, which genes for the parents and fetuses. So we're doing a lot of social scientist work there. And attaining patient preferences and when and how to obtain consent and return results. So when do they want that results, and like actually for the incidental findings, should we be reporting them when they've got the scan anomalies in front of them, or should we wait for later in pregnancy or when the baby is born? So that type of work. So we all know whole exome sequencing is not ideal. It's cheaper, has less issues with data storage, but we really want to move to whole genome sequencing. Why? It's the whole genome. You've not just got your protein coding region, you get your non-coding genes. It gives much more uniform coverage and complete coverage of genes. You get less errors because you don't have your PCR artifacts. It's quicker library preparation, so it means you can actually do things a lot quicker in the lab. So then you can get a quicker turnaround time, better identification. I don't need to tell the team here of chromosomal abnormalities. You can get structural variants and that are balanced, as well as the copy number variants. We're hoping eventually for some indications we might therefore be able to stop doing microarray testing in parallel and just move to using WGS, for example, for the skeletal dysplasias. And for us, it's already on offer in the NHS postnatally, but it isn't prenatally. And for us, prenatal makes much more sense to do the most comprehensive test because you have your limited sample. You might not get a chance to have another sample. So our argument is we should be doing WGS prenatally, especially if you're doing it postnatally. And yeah, it is offered postnatally. So if they terminate the pregnancy or the baby delivers, they do qualify for WGS. So at the moment, if you have an exome sequencing our panel and it doesn't detect something, you would then have WGS postnatally, and that is not a cost-effective model. So for us to be able to move to WGS, we had to address a number of challenges. So we need to work on data storage, DNA input, bioinformatics pipeline validation, and increased costs. So this means we needed to do a research study. But because our exome sequencer 7 was also up and running, we couldn't really do it on prenatal. So we needed to find another indication to do. So this leads to working, so talking about a non-prenatal cohort. So we work international with 3 other institutes around the world for the Gene Steps projects, which works on epilepsy. So it's a multi-center study. So the eligibility criteria are for infants with seizure onset below 12 months, and we do rapid WGS testing. And we're doing clinical follow-up to follow them through and see how getting this result is going to improve looking at the treatment choices and their developmental outcome. So these are patients that aren't on intensive care, because there's been a lot of work on rapid WGS on patients in intensive care, and there is a service already in the NHS for those patients. So these are patients that are ambulatory and walking around in day cases, so not the severe end of the spectrum. So the first 100 cases internationally, we were able to published in the Lancet Neurology last year. Our diagnostic yield is around 43% and 50%. So I think epilepsy, the genetic inheritance is much more well known. So the yields are generally higher for epilepsy. We've been able to deliver it in 17 calendar days. So we've shown we can do WGS quicker. I mean, I think we could do it's a lot quicker if we have more resources. At the moment, we just have one person in the research environment doing it as quick as they can. So definitely in a clinical service, we can get that TAT down. What we are now doing is we've got our diagnostic yield. We're working with our clinicians to review all of the cases. We have our new brain mosaicism test to see if there's a mosaic variant in the brain causing the epilepsy. So we're going to do that. But then we're also trying a lot of different reanalysis strategies in the data to try and find ways of increasing our diagnostic yield. We're working with the international cohort on that. But what this did was it allowed us to get some cases that would have been missed by exome. It allowed us to develop all our pipelines and our technical team trained up, ready to be able to do our prenatal validation. So what we were using for gene steps was the standard input protocol, PCR-free 1000 nanograms. It takes about 2.5 hours, but we're only doing a single trio per run, which wouldn't be cost effective for us in the NHS for prenatal. We need to multiplex the samples. We need to bring it as close as possible as we can to the exome sequencing cost. Also, the input of DNA for our exomes, we use 50 nanograms. They're 1000 nanograms. A lot of the time we wouldn't have enough DNA without culturing. So what I was ambitious with doing, I was like, well, let's try 50 nanograms. Let's try what we have for exome. Keeping it PCR free, because that is the most important thing out of WGS, otherwise you lose all your benefits. So I had a go, and we've managed to, we do 7 trios in one run on a Illumina Nova 6000 currently. And it works absolutely fine with 50 nanograms of DNA. We just had to make one change to the protocol, which is what Illumina suggested anyway, but using qPCR rather than qubit. So it adds a little bit longer to your test workflow, but it's still a lot easier than exome sequencing. So you managed to get that working absolutely fine. We've now performed testing on 31 prenatal samples, all direct extractions. And we use 15x coverage as our metric to match Genomics England, who do the postnatal WGS for WGS. It's over 99% for the fetal anomalies panel, which for the exome sequencing 98%. So we've demonstrated it's got better coverage or completeness. All SMVs and CMVs that were truly heterozygous or heterozygous or homozygous or hemizygous were detected. We have one mosaic variant that we haven't managed to detect, but also we didn't detect that with the exome sequencing either. I keep meaning to change that bit. It was a mosaic trisomy 16, not UPD16. It wasn't detected because what we've been doing in our validation has been trying to put in lots of structural variants and CMVs of the move to hopefully kind of be able to look at getting more information on our CMVs and looking at more structural variants and really start working on our structural variant pipeline. So we can see this trisomy 16 in the data. We just haven't developed our pipeline to be able to call it, but we can see it's there. So we just need to work out how we can develop our pipeline to call it. So we need to a lot more work with hopefully help from the team here to be able to hopefully always have to remove the requirement for array. We also have tested 40 postnatal samples from blood, and so the autosomal genome, they're all over 91%, which matches the Genomics England gel, which is what we have to benchmark to. So we've submitted the business case to NHS England in December 2023 and to justify why we should be moving to WGS with the costs. and all the data we've got from our research pilots. So we're still awaiting the outcome. One of the challenges we have is that Birmingham, who's the other centre that offer the testing, are not ready to move to WGS. So it's how we can offer equitable testing using different technologies, even though it's going to hold us back from our testing. But it's got to be like, we understand it needs to be fair across the country. So we're also helping Birmingham to come on board. But they haven't done any research work yet, so it's going to take a little while to get them ready. So what are the benefits of the nationally public funded service? So equity of access and standardization, and eligibility and reporting across the country is the same, and it's all public health service, and it's really supported by the multidisciplinary team working. So it has no cost to the parents, and it's delivered fully through, everything is publicly funded throughout. The results have been shown to be impacting on clinical management, and it's really important that we're collecting these outcomes, as I believe is being done here as well. It's dynamic, so it means because the two centres are aligned, we are able to like respond to new information, new changes. We meet monthly with NHS England, new phenotypes, we can add them to our panel eligibility criteria, though we have to complete all the paperwork. And we do try and contribute to international efforts to improve the fetal genotype correlations. So we've introduced the fetal genotype reports in prenatal diagnosis, which is what I'm editor for, to try and get them published. We're members of the ClinGen Prenatal Expert Curation Panel, and also the US Fetal Sequencing Consortium. And we do try and publish whenever we can. So just to conclude from our work, so our service, it kind of hosts a unique service by delivering, I think the NIPD is truly unique. There's not many centres offering bespoke testing for different variants. It delivers safe and more comprehensive prenatal diagnosis for monogenic conditions for our national NIPD, and our rapid sequencing service. I think it's really valued by our health professionals, the fact that it's publicly funding, and we do try and develop it. And it just there are great things about public funding, but one of the challenges is always trying to get more funds, and I think it's the same here. So the key requirements is really important. I think multidisciplinary team working, I think, is absolutely essential for being able to offer these services. I think expert fetal phenotyping, I think a lot of the problem is the quality of scans and being able to get that information. I think that is absolutely critical to being able to offer a prenatal service. So I think the quality of scans is somewhere we're trying to educate on as well. Standardizing the care pathways, doing appropriate validation. So everything we do in the research we do as if it's diagnostic. We don't treat it any differently. That way we can always use any research results straight away in a validation. We don't have to redo the work. Educating health professionals, working with quality assurance teams. So I'm trying to set up a quality assurance scheme for prenatal extractions, because they're highly variable, and trying to improve the quality. Educating health professionals and patients, working on the counselling, how we can improve it, what's worked well, what's done well. Data sharing, we currently aren't submitting any of our our things to the ClinVar database, but we're working on it with NHS England. Unfortunately, the information government's rules make it really challenging, but we are working on it. We know we always say you need to data share, so we are working to do it, because we feel like it's not fair saying it. And I think the funding and support for the research and development, it's hard to get. But it's really critical we are getting this, otherwise we can't move new technologies into public health if we can't do the research. So I think it's very important. So this, I mean, we've had so many different centres involved in all of this research. So these are just some of the ones we've worked with along the road, and these are our patient groups that are really important, because where any research grant, we know we need to have the patient advocacy groups. And these are the many different funders we've had throughout our work, so we appreciate them all. Thank you.